And our last speaker in this part of the session is Laurie Wren, who is well known to this audience and has been part of this management team for a long, long time. So it's a privilege, Laurie, to get you back on and see what your thinking is.
Counting on Dr. Howard to keep me on track so I stay within, which is never a problem. Never a problem. Thank you very much. I'm really, really pleased to be here. This is really one of my favorite groups to, work with and participate with. I also am really, really honored to be on the program this morning with Dr. Calkins and Dr. Chang, who really they are the future of our program. I'm so, their commitment and work on the behalf of this field has just been really, really exemplary. I am going to be talking about one of my favorite topics in life, central line care, but was asked to look at it from a little bit different perspective this morning, and looking in terms of societal standards, guidelines, evidence-based practice, and you. I do not have any financial relationships to disclose. I really want us to walk away from this morning's talk with a little bit better idea of what are some of the relevant practice standards and sources of evidence that really guide current recommendations for central venous catheter care. Oh, thank you. You knew that I was struggling. How do we incorporate the best evidence into our clinical practice? How do we translate to what's going on in your homes, what's going on with central venous catheter care at the hospitals and home care level? And also, how do we individualize central venous catheter regimens to address patient-specific variables and catheter-specific variables? Now, you may wonder where we get all this. Is there, you hear people say, oh, well, we're going by the guidelines, we're going by the standards, we're going by the research. But really, what's out there and how did we come up with all this? When we first started doing TPN in the 70s, there was not a huge research base to guide central venous catheter care. There weren't a lot of studies out there. We knew that there was kind of a surgical approach. You stuck a line into somebody, it's a surgical wound, you've got to keep the wound clean. But in terms of everything else, not a lot to go on. I remember when I was very, very early in my career, maybe, early 80s, I was asked to participate in a group through the American Society of Parenteral and Enteral Nutrition that was going to develop standards for central venous catheter care. And I remember sitting in a hotel in Chicago, and we spent 2 days talking about dressings and how to change dressings and what's the best agent for cleaning dressings. And at one point, and I came from a program where I worked with a doc who developed our first central venous catheter care protocol, and it was a good little system, and we paid a lot of attention to what we did to clean the line before we hooked up a flush or before we hooked up the infusion. And I said to this group, I said, we've been talking about the dressing for 2 days. What about what we do when we, access the catheter to hook things up and flush? And they all looked at me and said, well, nothing. That's just part of the infusion system. And now here we are 30 years later, and we've got a lot of different literature and stuff out there about, locks and, biofilm and all that. So there's a lot that's gone on we've made a lot of progress, and yet we haven't made a lot of progress. So I want to just get you, this is like going to graduate school, but just to kind of familiarize you with some of the terms that you'll hear people use when they talk about what they base their decisions and protocols for catheter care off of. So number one, we've got guidelines. And guidelines are documents that are developed with the aim of guiding decisions regarding diagnosis, management, and treatment in specific areas of healthcare. They are issued by official bodies. So what's an official body? Well, the Center for Disease Control is an official body, and they're actually the source of one of our kind of foundational documents that guides catheter care, which is their guidelines for management of vascular access devices. Other organizations have guidelines or standards. The Infusion Nursing Society has standards, American Society of Parenteral Nutrition. A lot of different bodies can issue guidelines. Important thing about guidelines is that they're evidence-based. They're based on some sort of proof that what we're saying, what they're recommending, works. So we're going to talk a little bit about evidence, because evidence can be really strong evidence, or evidence can be really weak evidence. And so you have to have a way to kind of look at that. So evidence-based medicine is really a term that kind of gained a field that really kind of took off in the 90s. So prior to that, we had a lot of, decision making for a variety of disease processes based on people's kind of experience and clinical judgment and, what they thought worked. But really, as we started to develop, larger experience and more research that really pointed to, what maybe were best practices, really there was a lot of emphasis by a lot of different official bodies to really look at the evidence and look at the research and base practice and practice guidelines on what we knew from the research. So it's become much less acceptable, much lower standard of care to say, well, I do it this way because that's the way I always do it. You really want to have somebody say, this is the evidence, to be able to say, gee, when you're on, when you have a step procedure, these are the numbers, this is what we know based on the research. So evidence matters. But evidence, when you look at guidelines, evidence is graded. You get a grade on your evidence. So the highest level of evidence is, studies that are what are called randomized and prospective. They have large numbers, so they have really statistical strength to really prove their point. Gotta tell you, in the field of central venous catheter care, those studies exist mostly in inpatient acute care settings. They don't necessarily exist for home care settings. So what we have a lot of for home care and on the home realm are retrospective studies looking at a group of patients and what happened to them, over time based on maybe what kind of dressing they used or what kind of, cleaning agent they used. But we don't have as strong a grades of evidence. Weaker grades of evidence, which are also included as grades of evidence, are clinical case reports. We had 2 patients that developed this weird rash when they used a specific cleaning agent. Well, that's important to know, because that may be something that comes up for other people, but it's a weaker level of evidence. And actually, expert opinion is still considered, in grades of evidence, but it's probably the weakest. Although I love expert opinion. I have a lot of opinions, and I like sharing them, and I think they're valuable. Anyhow, but so you got to realize when you see, people say, well, there was a study that showed that BioPatch works great for everybody. Well, the study actually says that BioPatch works really well for people's in a surgical ICU with a short-term percutaneous, internal jugular line. So you have to kind of look, when people are making recommendations based on a study, you have to look at who they studied and what's the circumstance was, and is it similar to your situation. Now, there's a whole nother realm of, practice guidance, and these are standards, and standards are agreed upon structures and processes designed to ensure that a specific product or service or method of doing something is performed consistently at a designated level. I have been living standards the last week. My institution just had a joint commission review, and you are reviewed against a set of standards. Joint Commission is an accrediting body that is really considered a mark of quality for healthcare services. There are inpatient Joint Commission standards, there are home care Joint Commission standards, and those standards ensure everything from things like structures that make sure the clean room where they mix your TPN is up to standards. They ensure that the nurses have the appropriate competencies to teach you or to provide care. And they also really look at what kind of outcomes, you should be tracking and monitoring. So as you can see, we've got a whole jumble of stuff, and sometimes people throw around terms interchangeably, but really, you're probably going, what does this all mean for me? Well, let's talk about what it means for me, for you, for all of us. Where do we get some of the evidence that really guides, what we are teaching consumers and families about central venous catheter care, what we are teaching our nurses and caregivers about central venous catheter care? Well, as I said, the CDC guidelines are one of the most robust sources of evidence. They are updated on a regular basis, but as you can see, the most current update is 2011. So you go, okay, if it was published in 2011, that means they were working on it for several years before 2011. So the data, the evidence is not necessarily the most current evidence. So things come along since then. But in terms of a really robust evidence-based document that's pretty comprehensive, that's kind of our gold standard. Now, other organizations have standards and guidelines. Infusion nurses just reviewed their standards, and they're updated in 2015. When you look at their standards, they look very similar they're very strongly based off of the CDC. If you look at the hospital epidemiology standards for prevention of central venous catheter care, they look very similar to the CDC. There's, a pool of evidence that everybody pulls from, and it ends up looking kind of, you recognize stuff. When you look at the research relating to central venous catheter care, the majority of the big studies are focused on inpatient, acute, and critical care settings. There is a more robust and growing body of literature internationally looking at folks in the home care setting, but there really is a paucity of big standardized, randomized controlled studies in the outpatient setting. What is the best evidence? So when you look at evidence, when you look through, for example, the CDC guidelines, there's not a whole lot of them that hit the best evidence. 1A is the best you can do. So what are some of the category 1As from the CDC? Education of healthcare personnel, periodic assessment of knowledge and adherence to adherence for all personnel involved in maintaining CVCs, designating only competent personnel for maintenance of CVCs. CHG for skin prep is another 1A. Dressings, sterile, gauze, or transparent. That's a 1A. So it doesn't answer the question. It's both options are valuable. And scrubbing access ports with an appropriate antiseptic and access with a sterile device. So yeah, but does that mean, what are we saying? Are we saying alcohol? Are we saying chloroprep? Are we saying povidone? It doesn't say. It says any of the three. So that's the best evidence. And you're going, that doesn't give me as much specificity as I like in knowing what's best. So we're not going to talk a lot of specifics in the time we have this morning, but I'll do a session this afternoon, and if you have specific questions, we'll talk about it. But here are the questions to ponder based on all this. How does all that translate to the home setting? How does that translate into meeting the education needs of patients and consumers and family caregivers? How do we ensure competency in consumer and family caregivers? How do we assess adherence in consumers and family caregivers? And how do we design care regimens that address specific risk factors and promote best outcomes? So a lot to think about. And the other thing with competency, how do we ensure that the people that are providing the education to consumers and family caregivers are operating at a grade 1A level? So one of the things to realize when we're customizing regimens, why one size may not fit all, is risk factors are going to vary for central line associated bloodstream infections. I see people smiling. This is a pediatric picture, but it could be an adult picture, and it really demonstrates some of the risk factors. Age is a risk factor, the very young and the very old. Underlying disease, shorter length of intestine, Crohn's disease has been cited as a risk factor. Comorbidities, wounds, ulcers, ostomies, opiate dependence. So, and you look at this little tyke, and that's she's a landmine, and she was a landmine, and we've improved it, and it's things like this is less of a landmine. And this is this is one of our nurses really promoted an initiative that we've translated to home. It's called Lines Up, Tubes Down, but really trying to create separation of church and state in terms of risk factors. So other things are risk factors: practice patterns, type of lines, subcutaneous port versus multi-lumen catheters versus PICC versus tunneled, frequency of infusion. There's some literature that evidence people that infuse less may have lower risk factors, which less handling of the catheter. So it translates like that. Blood draws through the CVC have been, in some small studies, implicated as potentially a risk factor, and use of the line for non-PN indications. So again, more access, more risk. And then there's some psychosocial factors. There are a variety of studies that show that folks on public insurance tend to have higher rates of infection. They don't really say why, and it may be an issue of access to care. It may be an issue of access to care for the purposes of support in education and monitoring. Multiple caregivers, more is not necessarily better. A small, consistent group may be better than a whole village. It's very interesting, and no disrespect to any home care nurses in the audience, but there are studies that demonstrate that patients that rely primarily on home care nurses for their care may have, their outcomes may not be as good where you have consistent family or individual caregivers. And experience is another risk factor. Lack of experience. There's multiple small studies that demonstrate the first year on parenteral nutrition with a central line, there is a learning curve, so they tend to have more complications in the first year of therapy versus the subsequent year. So what do we do about all this? So what are the protective factors? And there's multiple studies that show that education and training, access to centers of experience, and affiliation with social support organizations. And I have a quote from one of our consumers that says, I keep going to support groups and Oley and attend line care sessions because it's a refresher course each time on how essential good line care technique is, and that it can't be forgotten or taken lightly. And one of the things when I was reviewing the guidelines, I really, we do an annual review for all our nursing folks. We don't do an annual review for our consumers. And this year I've had 3 separate incidents where I've had long-term consumers with excellent records, have gone years and years at time without an infection, that presented to clinic and said, for the last few weeks I've just been so chilly at night. I have to cuddle under the blankets till I get all toasty warm. And I'm like, for God's sakes, we're going to culture you. You're growing, organisms with the last 25, but they sort of forgot. And I felt bad because I think that says to me, we got to refresh. We've got to review on a regular basis. Because even in the best of situations, you may kind of forget that this is what you should be on the lookout for. Building the perfect line care regimen, here's what I think. It's got to be evidence-based to the best of the evidence. It's got to be systematic and ritualized so it incorporates aseptic technique, minimizes the risks of touch contaminations, provides adequate contact time and friction with antiseptics, has some redundancy built into it, some checks and balances. So if you screw up one place, you've got a chance to recover in another place. And it's comprehensive. It covers all aspects of infusion care, not just scrubbing the hub, but what do you do? What are you doing with, your syringes and the end of your tubing? And it's very proactive in anticipating and planning for patient specific risks. And the other thing that I really want you to think about is that it's mindful. It's really focused on what you're doing and why you're doing it. Mindfulness has gotten a lot of play in healthcare now. It's got a lot of benefits, but it's really a mental state that is really focusing one's awareness on the present moment and calmly acknowledging and accepting what's going on around you. So in the little cartoon there, it's like mindful or mindful. And most of us walk around mindful all the time. A lot of distractions, a lot of stuff going on. So mindfulness with your line care is really, providing that focus and intention on what you're doing and why you're doing it. And another quote, as far as mindset, I really think about the time I'll spend in the hospital or in the ER, or missing work and family time, so that if I don't do what I need to do in order to stay free of complications, I essentially am asking, do I want to take the extra 5 minutes to prevent the days I'll spend in fighting an infection or stuck in the hospital? And this is another quote from a parent. It says, if a caregiver doesn't understand the gravity and purpose of their care in terms of infection prevention, they're not going to be as compliant or effective. When a caregiver is scrubbing the hub because that's the rule, versus thinking about the person's lifeline and how to protect the bloodstream from infection at every access point of anything that's going into the line or the body, if you don't have that focus, there's potential for error. So, final thoughts. It's a bundle. It's not a silver bullet. It's not just one thing that contributes to success. That's hand washing is where it all begins. And hand washing is one of the most simple, effective, and most overlooked things. Not just what you're doing. One of the things, and we always tell you to speak up. We always tell you to speak up if you don't see somebody wash their hands, or they don't. I had an experience recently where I had a family friend in the hospital who had a PICC line. And I really came face to face with all these years, I'm blah, 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 speak up, speak up. And I had the PICC line there was an occlusion beeping. And I couldn't fix it. So I said to the nurse, could you get in here and, fix this? And the nurse, in the blink of an eye, bare hands, not washed, twisted off the tubing from the PICC line, pulled it out from the sleeve of the gown, dropped it on the bed, hooked it back up to the PICC line. It happened so fast. And I'm sitting there going, wait. And they just looked at me and go, it's okay. I'm like, it's not okay. But it really realized, if I'm telling people, it's hard. I know it's hard. It doesn't mean you don't do it, but it's really hard. This afternoon, we're going to talk about dressing management and some of the different strategies for dressing management. Is there a right answer? It depends. It depends on you. It depends on the climate you live in. It depends on the condition of your skin. It depends on your lifestyle. We're going to talk a little bit about scrubbing agents and application devices. Here's my thing on scrubbing. I don't care what you scrub with. Scrub hard. Make sure you've got adequate contact time for the agent you're using. Make sure you've got adequate friction. I have a woman in the room here. When I watch her scrub her kid's hub, you know who I'm talking about. I see steam coming out of her ears. There is so much intention and elbow grease that there's a tremendous amount of friction and contact time. You want to do whatever you can to minimize the risk of touch contamination and do it enough so you've protected for any things. This is one of my favorite slides. This is actually from the anesthesia literature, and it just kind of illustrates the importance of contact time. They contaminated with glow germ, and at 5 seconds, there was still glow germ there. At 10 seconds, there was still glow germ there. When they got to 15 seconds, they got a pretty good clearance. So again, show this to anybody you want to. This will be up on the website. It's a one-page article from an anesthesiologist, which they're sometimes our worst offenders, but they thought enough to do it. Final thoughts, challenges in education. there are variabilities in teachers. There's variabilities in your teacher's knowledge and skill as a teacher. There are variabilities in learners. Not everybody learns the same way, and a good teacher knows how to vary their teaching techniques so their students can all be successful. There are very often in some settings variability, lack of standardized instructional goals and materials. And the setting where you learn may make a difference. There's actually studies in Europe that have looked at, do people do better when they learn at home or in the hospital? Amount of education, studies looking at more intensive education, do you have better outcomes? And social support. This is our shout out to Oley, that there actually was a study that showed that affiliation with a national support and educational organization do improve outcomes. So just by the fact of being here today, you've taken an important step in terms of ensuring that whatever your outcomes are, they're either continue to be great or they're going to be improved. So with that, I always end with a slide of camp, and this is another just shout out for another way for social support and independence. And camp changes kids. Camp also changes nurses, because by the time I've spent a week at camp wrangling 10 to 12 kids on TPN, I have a whole different appreciation for what you live with every single day. So with that, thank you for the opportunity, and we'll take any questions.
So that was a presentation of somebody who's seen it all and done that. Okay, Jack.
Yeah, two questions. One is I have a PICC line, and I have my dressing changed every week by a nurse. So from a home health, right, nursing. So I have no insight into whether she's doing it right or not. I think she has been. We've got the same person. But how do you in general know whether those people are meeting standards? And then secondly, is there anybody responsible for that? For example, I've got my TPM provider, I've got my GI, I've got all that, but is it basically who holds them right to the standards of doing that?
So the agency that employs them is responsible for ensuring that they have the appropriate education and competency to provide the care they're providing to you. This can be variable. You should be able to say, what is your protocol? What is your procedure for PICC line dressing change? I mean, I think the fact that you've got a consistent nurse is really great for our folks that tend to have more consistency versus having a different person every week. That tends to promote, the ability to kind of really, develop some, hopefully, trust and confidence. But, now I'll tell you something. When we send folks out, we send them the policy that we want followed. We do not leave it up to whatever the home care nursing agency's, policy is. That's not the case everywhere, so, depending on where you're coming out of. But there are standardized policies available to look at. And I would ask them to say, what's your policy? Is your policy, you should expect to see hand hygiene. You should expect to see, for a PICC line dressing, it's a sterile dressing change. So you can ask those questions, and you should, but the agency that employs them is responsible for ensuring they meet a minimum standard of competency.
A question over here.
Sorry,
and
just
then
also a
probably
quick
we're
comment
going
to piggyback
take
that,
a
and just
short break.
really
Okay.
watching home care nurses just in the midst of moving and all that. My daughter was getting established with a different home care nurse. In the blink of an eye, in her blood draws, I didn't realize that the nurse was going through a cap change, non-sterile, bare hands after a blood draw. I was aghast
You should
for
be.
several minutes, and subsequently did report her, and we did go back to her original nurse through that agency at the time. But also just to get an idea from you on the Drew a blank there. The efficacy also of trying to make sure your pumps work correctly for administration time through the catheter that you have. Do you see a variancy with even pumps working with catheter care differently, or is there really a standardized making sure that there are pumps working correctly for the right dosage time through a catheter?
So that is, I have a variety of consumers that use a variety of pumps. I think the responsibility for making sure that the pump is, performing at, the optimal level is your home infusion provider. And they should be bringing back your pump on a regular basis for servicing and testing and all that kind of stuff. I personally do not see a lot of variability in outcomes related to what kind of pump people are using, but it is the responsibility of the agency that's providing you with the pump to make sure it's serviced and operating at, the designated standard.
This is the last question.
I'll make it a good one. So we have been, over the years, we've seen a lot of standards of care in different hospital settings. Currently, my daughter is followed in a transplant clinic, although she hasn't had a transplant, and we're always really impressed by the level of following protocol of the nurses there. But whenever she's in any other part of the same hospital, whether it's the emergency room or if they put her in the ICU, it's like a different world. Do you have any thoughts about how we can, other than what we often do, which is say, don't worry, we'll do that, and do all the care ourselves, or she does it herself? Do you have any thoughts about how we can approach the administration of a hospital or?
Approach the administration. I will say at our institution, one of the things that has really also over the years has really changed is this is all publicly reportable now. When there are, hospital-acquired infections of any kind, and especially central line-associated bloodstream infections, it's publicly reportable. We report it to the state, we report it nationally. It's showing up in your measures for leapfrog, which are, consumer, judgments of, is this a quality hospital or it's not a quality hospital. A good, these practice settings, now ER is a problem because they never know. They don't get data on how many infections occurred in the ER. But, your ICUs, every unit, they should be getting their data on a monthly basis. And they should be, held to, we are always trying to hit our benchmark. It's really hard. Sustainability is terrible. But one of the most effective things I have seen, at least in our organization, is we had a family advisory council that really, and we had a lot of families that had children from a variety, hem-onc, transplant, TPN, that had kids with central venous catheters. And they were all having the same experiences in the ER, in radiology, in, different parts of the hospital. And they became like one of our strongest, they really partnered with all those parts of the hospital. They made a line care video that is shown in all these departments, really speaking as a parent to, what you are doing to, really think about what risk you're putting my child at, what you're, putting this family through. So, I think that's another more formalized way of going about it, but, you have to use right to the director of nursing, right to, take it up the chain of command.
Very good.